The morning sun cast long shadows across the Seattle waterfront as Sarah Mitchell laced up her running shoes outside her modest apartment. At 28, she appeared to be just another young professional starting her day with exercise. Her slight frame and quiet demeanor gave no hint of the extraordinary life she had lived or the battles she had fought in places most people couldn't pronounce. Sarah had been back in civilian life for 8 months now, but the transition felt more challenging than any mission she had undertaken during her 6 years as a Navy SEAL. The daily routine of running helped quiet the voices in her head and provided structure in a world that often felt chaotic and unpredictable. She preferred the early morning hours when the streets were mostly empty, allowing her to move through the city without drawing attention or engaging in small talk that might lead to uncomfortable questions about her past. As she began her usual 5-mile route along the waterfront, Sarah's mind wandered to the job interview she had scheduled for later that morning. The position was with a private security firm, and, while it wasn't exactly what she had envisioned for her post-military career, it would utilize some of her specialized skills and provide the financial stability she needed. The interviewer had seemed impressed by her resume, though she had been careful to downplay certain aspects of her military service that might make people uncomfortable or raise questions she wasn't ready to answer. The irony wasn't lost on her that she was applying for a job protecting others when she often struggled to protect herself from the memories that haunted her sleep. The nightmares had become less frequent in recent months, but they still arrived without warning, leaving her drenched in sweat and fighting the urge to check every window and door in her apartment. Her therapist at the VA hospital had explained that this was normal for combat veterans, but knowing something was normal didn't make it any easier to live with. Sarah had always been smaller than her peers, a fact that had worked both for and against her throughout her military career. During SEAL training, instructors had initially doubted her ability to meet the physical demands of the program. She had proven them wrong by not only completing the training but excelling in areas that required precision, stealth, and mental toughness rather than pure physical strength. Her size had become an asset during covert operations, allowing her to move through spaces and blend into environments where larger operators might struggle. The decision to leave the military had not been an easy one. Sarah had loved the sense of purpose and the brotherhood that came with being part of an elite unit. But, after her third deployment, she had begun to feel the weight of everything she had seen and done. The final straw had come during a mission in Afghanistan when her team had been tasked with eliminating a high-value target who turned out to be younger than she had expected. The mission was successful by all military measures, but something inside her had shifted that day, and she knew it was time to find a different path. Returning to civilian life had presented challenges she hadn't anticipated. The skills that made her exceptional as a Navy SEAL didn't always translate well to typical workplace environments. Her ability to remain calm under extreme pressure was an asset, but her direct communication style and intolerance for inefficiency sometimes rubbed colleagues the wrong way. She had learned to soften her approach, but it felt like wearing a costume that didn't quite fit. As she rounded the corner onto Pine Street, Sarah noticed her breathing had become more labored than usual. She attributed it to the slight incline and the humid morning air, but as she continued running, the sensation intensified. A strange tightness began to develop in her chest, accompanied by a dull ache that radiated down her left arm. She slowed her pace, thinking perhaps she had pushed herself too hard the previous day during her workout at the gym. The symptoms continued to worsen as she made her way up the hill toward Pike Place Market. Sarah had experienced discomfort during physical exertion before, particularly during the grueling training exercises that were part of SEAL preparation, but this felt different. The pain was becoming more acute, and she was beginning to feel lightheaded. She stopped running and walked to a nearby bench, hoping that a brief rest would help her recover. Sitting on the bench, Sarah tried to analyze what was happening to her body with the same methodical approach she had used to assess threats during combat operations. Her pulse was irregular, and the chest pain was becoming more intense rather than subsiding with rest. She considered the possibility that she might be having some kind of cardiac event, but quickly dismissed the idea. She was young, fit, and had no family history of heart disease. Her last military physical had shown no signs of cardiovascular problems. As the minutes passed, however, the symptoms became impossible to ignore. Sarah's vision began to blur slightly, and she felt a wave of nausea wash over her. The rational part of her mind was telling her that she needed medical attention, but another part of her resisted the idea of appearing weak or vulnerable. Throughout her military career, she had been trained to push through discomfort and maintain mission focus regardless of physical challenges. A jogger passing by noticed Sarah clutching her chest and stopped to ask if she was all right. Sarah tried to wave him off, insisting that she just needed a moment to catch her breath, but her voice sounded weak even to her own ears. The Good Samaritan wasn't convinced and pulled out his phone to call for emergency medical assistance, despite Sarah's protests that it wasn't necessary. Within minutes, the sound of sirens could be heard approaching from the distance. Sarah felt embarrassed by the attention and worried about the cost of emergency medical services, particularly given her current unemployment status. She had good insurance through the VA, but emergency room visits could still result in significant out-of-pocket expenses. More than the financial concern, though, was her discomfort with being the center of attention and having to explain her situation to strangers. The paramedics who arrived on the scene were a team of 2 men who appeared to be in their 40s. They approached Sarah with professional efficiency, immediately beginning to assess her condition and ask about her symptoms. Sarah provided clear, concise answers to their questions, describing the chest pain, shortness of breath, and radiating discomfort in her arm. She also mentioned that she had been feeling unusually fatigued for the past few days, though she had attributed it to the stress of job searching and adjusting to civilian life. One of the paramedics, whose name tag identified him as Rodriguez, began taking Sarah's vital signs while his partner, Johnson, prepared the stretcher. Sarah's blood pressure was elevated, and her heart rate was irregular. Rodriguez frowned as he reviewed the readings on his equipment, then looked at his partner with an expression that Sarah recognized from her military experience as concern mixed with uncertainty. "How old did you say you were, miss?" Rodriguez asked, double-checking the information on his clipboard. 28, Sarah replied, noticing the skeptical look that passed between the 2 paramedics. Johnson stepped closer and spoke in a voice that he probably thought Sarah couldn't hear clearly. "She's pretty young for a cardiac event. Probably just anxiety or maybe drug-related. These days, you never know what people are taking." Sarah felt a flash of anger at the assumption, but she forced herself to remain calm. She had encountered similar attitudes during her military service, where her youth and gender had sometimes led to assumptions about her capabilities or character. She had learned that responding with emotion typically made situations worse rather than better. Rodriguez continued his assessment, checking Sarah's pulse and examining her pupils. "Ma'am, we're going to need to transport you to the hospital for further evaluation. Your symptoms could indicate a serious cardiac issue, but we'll need more sophisticated equipment to make a proper diagnosis." As they prepared to load her onto the stretcher, Sarah overheard Johnson speaking into his radio to the dispatch center. His tone was casual, almost dismissive. "We've got a possible cardiac event, but the patient is a young female with no obvious risk factors. Could be anxiety-related or substance abuse. We're transporting to Harborview, but this probably isn't going to be a high-priority case." The word stung more than Sarah wanted to admit. Throughout her adult life, she had grown accustomed to being underestimated and overlooked, but she had thought that a medical emergency would be different. The fact that these trained professionals were making assumptions about her based on her appearance and age felt like a betrayal of the trust that patients were supposed to be able to place in emergency responders. During the ambulance ride to Harborview Medical Center, Sarah's condition continued to deteriorate. The chest pain intensified, and she began to experience difficulty breathing that couldn't be attributed to anxiety or panic. Rodriguez, who was monitoring her vital signs, noted that her blood pressure was continuing to rise and her heart rhythm was becoming increasingly irregular. Despite these concerning developments, Johnson maintained his skeptical attitude about the severity of her condition. "Probably just having a panic attack," Johnson muttered as he filled out paperwork. "Young people these days don't know how to handle stress. Everything's a crisis." Sarah closed her eyes and tried to focus on her breathing techniques, the same one she had used to remain calm during high-stress missions. She reminded herself that she had survived situations far more dangerous than this, and that she would find a way through whatever was happening to her now. But, as the ambulance pulled up to the hospital emergency entrance, she couldn't shake the feeling that her biggest battle might just be getting the medical staff to take her seriously. The emergency room at Harborview was bustling with activity when Sarah's stretcher was wheeled through the automatic doors. Nurses, doctors, and support staff moved efficiently between treatment rooms, attending to patients with various levels of urgency. Sarah was taken to a triage area where a nurse named Patricia began reviewing the information provided by the paramedics and conducting her own preliminary assessment. Patricia was professional but seemed rushed, glancing frequently at the clock on the wall as she asked Sarah about her symptoms and medical history. When Sarah mentioned that she was a veteran, Patricia made a note in her chart but didn't ask any follow-up questions about her military service or whether it might be relevant to her current condition. "Have you been under any unusual stress lately?" Patricia asked, her pen poised over the clipboard. Sarah considered how to answer the question. The transition from military to civilian life was inherently stressful, and she had been dealing with financial pressures related to her job search. But she also knew that mentioning stress or anxiety would likely reinforce the assumption that her symptoms were psychological rather than physical. "No more than usual," she replied carefully. "I'm between jobs right now, but that's not particularly unusual for someone transitioning out of the military." Patricia nodded absently and continued with her questions about drug use, alcohol consumption, and family medical history. Sarah answered honestly, explaining that she rarely drank, had never used illegal drugs, and had no known family history of heart disease. She also mentioned that she maintained a regular exercise routine and generally followed a healthy lifestyle. Despite providing clear answers to all of the nurses' questions, Sarah could sense that Patricia was already forming conclusions about her case. The way she filled out the forms and the questions she chose to emphasize suggested that she was leaning toward a diagnosis that didn't involve serious cardiac issues. Sarah had learned to read people during her military service, and she could tell that the medical staff was not taking her condition as seriously as they would for an older patient presenting with similar symptoms. After completing the initial assessment, Patricia informed Sarah that she would be seen by a doctor shortly, but that there were several more urgent cases ahead of her in the queue. Sarah was moved to a bed in the main emergency room area, where she was surrounded by other patients in various stages of treatment. The environment was noisy and chaotic, with constant interruptions from staff members attending to different emergencies. As Sarah lay on the hospital bed, she reflected on the strange turn her day had taken. Just a few hours earlier, she had been preparing for a job interview that might have marked the beginning of a new chapter in her life. Now she was lying in an emergency room, experiencing symptoms that genuinely frightened her, while medical professionals seemed to doubt the severity of her condition. The irony of the situation wasn't lost on her. During her military service, she had been responsible for making life-and-death decisions under extreme pressure. She had earned the trust and respect of her teammates through her competence and reliability in dangerous situations. But, in this hospital bed, she was just another young woman whose complaints were being dismissed as likely psychological in nature. Sarah tried to remain patient and focus on the fact that she would eventually receive the care she needed. But, as the minutes turned into hours, and her condition continued to worsen rather than improve, she began to worry that the medical staff's assumptions about her case might prevent them from identifying what was really wrong with her. She had survived combat operations in some of the most dangerous places on Earth, but she was beginning to wonder if she would survive a healthcare system that seemed determined to overlook her in favor of patients who fit a more typical profile for serious medical emergencies. Dr. Marcus Webb had been working emergency medicine for 15 years, and he prided himself on his ability to quickly assess patients and prioritize cases based on severity. When he reviewed Sarah Mitchell's file that afternoon, he saw what appeared to be a straightforward case of a young woman experiencing anxiety or possibly drug-related symptoms. The paramedic's notes suggested skepticism about the cardiac nature of her complaints, and the triage nurse had classified her as low priority. Webb approached Sarah's bed with the efficient manner of someone who had seen thousands of similar cases. He glanced at her briefly before focusing on the chart, noting her age, the vague nature of her symptoms, and the lack of obvious risk factors for serious cardiac issues. In his experience, young women who presented with chest pain were usually dealing with anxiety, panic disorders, or sometimes seeking pain medication. "Miss Mitchell," he said, not making eye contact as he flipped through her paperwork. "I understand you're experiencing some chest discomfort. Can you tell me about any recent drug use or significant stressors in your life? Sarah felt the familiar frustration of being prejudged, but she maintained her composure. Doctor, I don't use drugs, and, while I'm dealing with normal life transitions, my symptoms are physical, not psychological. The chest pain has been getting progressively worse, and I'm experiencing shortness of breath that doesn't improve with rest. Dr. Webb finally looked up from the chart, his expression showing mild irritation at what he perceived as a typical patient insisting on a serious diagnosis for minor symptoms. Miss Mitchell, I understand that chest pain can be frightening, but, in someone your age, it's almost always related to anxiety, muscle strain, or other benign causes. Have you considered that you might be dealing with a panic attack? The dismissive tone in his voice triggered something in Sarah that she had worked hard to control since leaving the military. Throughout her career as a Navy SEAL, she had been forced to prove herself repeatedly to commanders who initially doubted her capabilities. She had learned to channel that frustration into focused determination, but, in this vulnerable state, it was becoming increasingly difficult to maintain her patience. Doctor, I've been trained to distinguish between psychological stress and physical symptoms, Sarah said, her voice remaining steady despite her growing concern. I'm telling you that something is seriously wrong with my cardiovascular system. I need you to run proper tests instead of making assumptions based on my demographics. Dr. Webb's expression hardened at what he interpreted as a challenge to his medical expertise. In his experience, patients who pushed back against his initial assessments were usually drug-seeking or suffering from anxiety disorders that made them hypersensitive to normal bodily sensations. He had learned to trust his instincts about these cases, and something about Sarah's demeanor struck him as manipulative. Miss Mitchell, I've been practicing emergency medicine for a long time, and I know how to identify serious cardiac events. Your symptoms simply don't match the profile of someone experiencing a genuine heart attack. I'm going to order some basic blood work and an EKG, but I suspect we're going to find that your heart is perfectly healthy. As Dr. Webb walked away to order the tests, Sarah closed her eyes and tried to process what was happening. The chest pain had intensified during their conversation, and she was beginning to experience a crushing sensation that made it difficult to take deep breaths. Her left arm felt numb, and she was starting to feel nauseated. These were textbook symptoms of a cardiac event, but apparently not when they occurred in a young woman who didn't fit the typical patient profile. The EKG technician who came to perform the test was a young man named Kevin who seemed more interested in finishing his shift than in providing quality patient care. He attached the electrodes to Sarah's chest and arms with mechanical efficiency, barely acknowledging her presence as he prepared the machine. Sarah tried to engage him in conversation about the test results, but Kevin seemed determined to avoid any discussion about her condition. The doctor will review the results and let you know what they show, Kevin said dismissively as he printed out the EKG strip and prepared to leave. Try to relax and not worry so much about every little sensation you feel. Sarah watched him walk away with the test results, feeling increasingly isolated and frustrated. She had spent years learning to advocate for herself and her team in challenging situations, but the medical environment seemed designed to discourage patient self-advocacy. The power dynamic between doctors and patients made it difficult for her to insist on proper care without appearing difficult or unreasonable. When Dr. Webb returned an hour later with the test results, his attitude had shifted from skeptical to openly annoyed. He carried the EKG printout and blood work results with the air of someone who had been vindicated in his initial assessment. Miss Mitchell, as I suspected, your EKG shows some minor irregularities that are well within normal limits for someone your age. Your blood work is also normal, with no signs of cardiac enzymes that would indicate heart muscle damage. What you're experiencing is almost certainly anxiety-related, possibly complicated by caffeine consumption or lack of sleep. Sarah looked at the EKG strip that Dr. Webb was holding, noting several abnormalities that seemed significant to her untrained eye. During her military service, she had received basic medical training that included reading EKGs, and the pattern on her test didn't look normal to her. Doctor, can you explain these irregular patterns on the EKG? And shouldn't you run additional tests to rule out other cardiac issues before concluding that this is anxiety-related? Dr. Webb's patience was clearly wearing thin. Miss Mitchell, I understand that it's natural to want explanations when you're feeling unwell, but you need to trust that I have the medical expertise to interpret these tests correctly. The irregularities you're seeing are minor variations that fall within normal parameters. Running additional unnecessary tests would be a waste of medical resources and would only increase your anxiety about a condition that doesn't exist. The conversation was interrupted by the arrival of a nurse who needed Dr. Webb to attend to another patient who had just been brought in by ambulance. As he prepared to leave, Dr. Webb turned back to Sarah with an expression of professional dismissal. I'm going to discharge you with a prescription for a mild anxiety medication and instructions to follow up with your primary care physician if the symptoms continue. I recommend that you consider speaking with a counselor about stress management techniques. Many young people today struggle with anxiety, and there's no shame in seeking help for psychological issues. Sarah felt a wave of disbelief wash over her as she realized that Dr. Webb was planning to send her home without addressing her worsening symptoms. The chest pain had become severe enough that she was having trouble speaking without pausing to catch her breath, and she was experiencing dizziness that made her reluctant to sit up too quickly. Doctor, I need you to understand that my symptoms are getting worse, not better. I can barely breathe properly, and the chest pain is becoming unbearable. Please don't discharge me without running more comprehensive tests. Dr. Webb paused at the foot of her bed, his expression showing clear irritation at what he perceived as a difficult patient refusing to accept his diagnosis. Miss Mitchell, I've explained your condition to you multiple times. Continuing to insist on unnecessary tests is not going to change the fact that you're experiencing anxiety-related symptoms. If you're not satisfied with the care you're receiving here, you're welcome to seek a second opinion elsewhere. As Dr. Webb walked away, Sarah realized that she was facing a situation that her military training had never prepared her for. During combat operations, she had always been able to rely on her team members to provide backup and support when facing overwhelming challenges. But, in this hospital bed, she was completely alone, and the people who were supposed to help her seemed determined to dismiss her concerns. The discharge nurse who came to process Sarah's paperwork was efficient but unsympathetic. She handed Sarah a prescription bottle and a printed sheet of instructions without making eye contact or asking about her current condition. Take one of these pills if you start feeling anxious, and follow up with your regular doctor within a week, the nurse said in a monotone voice. The discharge instructions include information about stress management and when to seek emergency care if your symptoms worsen. Sarah tried one more time to communicate the severity of her condition. I need you to understand that I'm not being discharged because I'm better. I'm being discharged because the medical staff doesn't believe that my symptoms are real. I think I'm having a serious cardiac event, and I'm afraid that going home right now could be dangerous. The discharge nurse looked up from her paperwork for the first time, but her expression showed annoyance rather than concern. Miss Mitchell, Dr. Webb is an experienced emergency physician who has determined that your condition doesn't require further treatment at this time. If you're not comfortable with his assessment, you can always return to the emergency room if your symptoms truly worsen. As Sarah signed the discharge papers, she felt a profound sense of abandonment and fear. Throughout her military career, she had faced life-threatening situations with confidence because she knew that her training and equipment would give her the tools to survive. But, in this medical crisis, she was being sent away with nothing more than anxiety medication and the suggestion that her symptoms were imaginary. The walk from the hospital bed to the exit felt like the longest journey Sarah had ever taken. Each step required significant effort, and she had to stop several times to rest and catch her breath. The chest pain was now constant and severe, radiating down both arms and making it difficult for her to carry her small backpack. She considered turning around and demanding to be readmitted, but the attitude of the medical staff had made it clear that they viewed her as a nuisance rather than a patient in need of care. Outside the hospital, Sarah sat on a bench near the bus stop and tried to figure out what to do next. She didn't have a car, and the idea of taking public transportation home while experiencing severe symptoms seemed dangerous. But she also didn't have the financial resources to pay for a taxi ride across the city, and she was reluctant to call any of her few civilian friends to ask for help. As she sat on the bench, Sarah reflected on the strange parallel between her current situation and some of the missions she had undertaken during her military service. During covert operations, she had often found herself alone in hostile territory, relying on her training and instincts to survive until backup could arrive. But, at least in those situations, she had been equipped with the tools and knowledge necessary to defend herself. Now she felt completely helpless, unable to convince the medical professionals who were supposed to help her that she was in genuine danger. A security guard from the hospital approached the bench where Sarah was sitting, apparently concerned that she had been in the same spot for an extended period. He was an older man with a kind face who seemed genuinely interested in her welfare. "Are you all right, miss? You look like you might be having some trouble." For a moment, Sarah considered telling him about her situation and asking for his help in getting readmitted to the hospital. But she realized that a security guard would have no authority to override the decisions made by the medical staff, and involving him would likely only create additional complications. "I'm just waiting for my ride," Sarah lied, forcing herself to smile despite the intense pain she was experiencing. "Thank you for checking on me, though. I appreciate your concern." The security guard studied her face for a moment, clearly not entirely convinced by her explanation, but ultimately deciding not to press the issue. "Well, if you need any help or if your ride doesn't show up, just let me know. I'll be doing rounds in this area for the rest of the afternoon." After he walked away, Sarah stood up slowly and began the difficult journey toward the bus stop. She had survived Taliban ambushes, improvised explosive devices, and firefights in some of the most dangerous regions of Afghanistan, but she had never felt as vulnerable and abandoned as she did walking away from that hospital. The realization that she might actually die because medical professionals had dismissed her symptoms as anxiety was almost too overwhelming to process. As the city bus approached the stop, Sarah made a silent promise to herself that she would find a way to survive this crisis, just as she had survived every other challenge in her life. But, as she climbed the steps onto the bus and felt another wave of crushing chest pain, she couldn't help but wonder if her determination would be enough to overcome a medical system that seemed determined to ignore her. The bus ride home became a nightmare that tested every survival skill Sarah had learned during her military career. As the vehicle lurched through Seattle traffic, each bump and sudden stop sent waves of pain through her chest that were becoming impossible to ignore. She gripped the metal handrail so tightly that her knuckles turned white, using the same breathing techniques that had kept her calm during firefights in Afghanistan. Other passengers occasionally glanced in her direction, perhaps noticing her pale complexion and labored breathing, but, in typical urban fashion, they avoided making eye contact or offering assistance. Sarah understood their reluctance to get involved with a stranger's problems, but the isolation felt profound as she struggled to maintain consciousness during what she was increasingly certain was a serious cardiac event. When the bus finally reached her stop, Sarah faced the daunting challenge of walking 3 blocks to her apartment while her condition continued to deteriorate. Each step required tremendous effort, and she had to pause frequently to lean against buildings or street signs while waves of dizziness threatened to overwhelm her. The anxiety medication that Dr. Webb had prescribed remained unopened in her pocket, as she knew that sedation was the last thing she needed while navigating the city streets alone. Sarah's apartment building was a modest 3-story structure in a neighborhood that was slowly gentrifying but still retained its working-class character. She had chosen the location partly because the rent was affordable on her military disability payments, but also because the area reminded her of the small town where she had grown up. The familiarity provided some comfort during her difficult transition to civilian life. Climbing the 2 flights of stairs to her apartment felt like scaling a mountain. Sarah had to stop on each landing to rest, her breathing becoming increasingly labored with each step. By the time she reached her door, she was struggling to remain upright, and her vision was beginning to blur around the edges. The simple act of inserting her key into the lock required multiple attempts because her hands were shaking so badly. Inside her apartment, Sarah collapsed onto her couch and tried to assess her situation objectively. Her military training had taught her to evaluate threats and develop contingency plans even under extreme stress, but this medical crisis presented challenges that were outside her area of expertise. She knew that her symptoms were worsening rather than improving, but the experience at the hospital had left her reluctant to seek additional medical attention. Sarah's apartment reflected her military background and current transition period. The furniture was minimal and functional, with few decorative items except for a small collection of photographs from her service and some books about career transitions for veterans. Her laptop sat open on a small desk near the window, displaying job search websites that she had been browsing earlier that morning before her world had turned upside down. As the afternoon wore on, Sarah's condition continued to deteriorate in ways that frightened her. The chest pain had evolved from uncomfortable pressure to severe crushing sensations that made it difficult to take full breaths. Her left arm had become almost completely numb, and she was experiencing intermittent episodes of nausea that left her feeling weak and disoriented. Perhaps most concerning was the irregular heartbeat that she could feel pounding in her chest. During her military service, Sarah had learned to monitor her heart rate during physical exertion and stress, and she could tell that something was seriously wrong with her cardiac rhythm. The beats were coming at irregular intervals, sometimes racing rapidly and then slowing to an almost imperceptible pace. Sarah considered calling 911 again, but the memory of her treatment at Harborview Medical Center made her hesitant to subject herself to another round of dismissive medical care. She worried that arriving at the same hospital twice in one day would reinforce the staff's perception that she was an anxious patient seeking attention rather than someone experiencing a genuine emergency. Instead, she decided to call the Veterans Affairs Hospital where she had been receiving mental health services since her discharge from the military. The VA medical system was familiar with treating young veterans who might present with unusual medical conditions related to their service, and she hoped that the staff there would be more willing to take her symptoms seriously. The phone rang several times before being answered by a receptionist who sounded rushed and overwhelmed. Sarah explained her situation and requested to speak with someone in the emergency department, but was told that the VA hospital didn't operate a full emergency room and that serious medical emergencies should be directed to civilian hospitals. "But I've already been to a civilian hospital, and they discharged me with anxiety medication," Sarah explained, trying to keep the desperation out of her voice. "I'm a veteran, and I think my symptoms might be related to my military service. Isn't there someone there who can evaluate me?" The receptionist put Sarah on hold for several minutes before returning with information about urgent care options and advice to return to the civilian emergency room if her symptoms were truly serious. The conversation left Sarah feeling even more isolated and frustrated with a medical system that seemed designed to pass patients between different facilities rather than provide comprehensive care. As evening approached, Sarah's symptoms reached a critical point that forced her to confront the possibility that she might not survive the night. The chest pain had become so severe that she could barely speak without gasping for breath, and she was experiencing episodes of dizziness that made her afraid to stand up or move around her apartment. Sarah used her laptop to research her symptoms online, knowing that internet medical information was often unreliable but desperate for any insight into what might be happening to her. The websites she consulted consistently pointed to serious cardiac conditions, particularly in light of her age and the progression of her symptoms over the course of the day. One article she found discussed a condition called spontaneous coronary artery dissection, which primarily affected young women and was often misdiagnosed as anxiety or stress-related issues. The symptoms described in the article matched her experience almost perfectly, including chest pain, shortness of breath, and irregular heartbeat in otherwise healthy young adults. Reading about the condition both validated Sarah's concerns and increased her fear about the potential consequences of delayed treatment. According to the medical literature, spontaneous coronary artery dissection could be life-threatening if not properly diagnosed and treated, but many patients experienced significant delays in receiving appropriate care because the condition didn't fit typical expectations about heart disease. As Sarah continued reading, she came across stories from other young women who had experienced similar dismissive treatment from emergency room staff when presenting with cardiac symptoms. The pattern was disturbingly familiar, with patients being told their symptoms were anxiety-related, drug-seeking behavior, or attention-seeking rather than genuine medical emergencies. The realization that her experience was part of a broader pattern of medical bias against young women provided some validation for her frustration, but it also highlighted the serious danger she was facing. If other women had died or suffered permanent damage because their symptoms were dismissed, there was no reason to believe that her situation would be treated any differently. Sarah decided to document her symptoms and the treatment she had received, both as a way to organize her thoughts and as a potential record in case something happened to her. She opened a new document on her laptop and began typing, describing the progression of her symptoms from that morning's run through her experience at the hospital and her current condition. Writing about her situation helped Sarah process what had happened and reinforced her conviction that she was experiencing a serious medical emergency rather than anxiety or psychological symptoms. The act of documenting her experience also reminded her of the after-action report she had written following military operations, where attention to detail and objective analysis were crucial for improving future performance. As she typed, Sarah reflected on the stark contrast between the respect and trust she had received as a Navy SEAL and the dismissive treatment she had encountered as a patient. During her military career, commanders and teammates had relied on her judgment and expertise in life or death situations, but, in the medical setting, her self-advocacy was viewed as problematic rather than valuable. The irony was particularly sharp given that Sarah's military training had specifically emphasized the importance of accurate threat assessment and decisive action in the face of danger. The same instincts that had kept her alive during combat operations were now telling her that she was facing a life-threatening situation, but the medical professionals who should have been helping her had chosen to ignore those warnings. As night fell, Sarah's condition continued to worsen in ways that made it increasingly difficult for her to remain conscious. The chest pain had become constant and severe, accompanied by shooting pains down both arms and a crushing sensation that made each breath a struggle. She was also experiencing periodic episodes of what felt like electrical shocks through her heart, followed by moments when her pulse seemed to stop completely before resuming at an irregular pace. Sarah knew that she was approaching a decision point where she would have to choose between seeking medical attention again or accepting the possibility that she might not survive the night in her apartment. The prospect of returning to the same hospital that had dismissed her concerns was almost as frightening as the idea of dying alone, but she was beginning to realize that she might not have any other options. She considered calling an ambulance and requesting transport to a different hospital, but she worried that the same dismissive attitudes might exist throughout the medical system. Her experience that morning had shattered her faith in the healthcare system's ability to provide appropriate care for patients who didn't fit typical demographic profiles. As Sarah sat on her couch, struggling to breathe and fighting waves of pain that threatened to overwhelm her consciousness, she made a decision that would prove to be the most important of her civilian life. She picked up her phone and dialed 911, knowing that she would rather face additional medical dismissal than die alone in her apartment without making every possible effort to save herself. The emergency dispatcher who answered her call was professional and efficient, asking standard questions about her location and symptoms. Sarah provided clear, concise answers despite her difficulty speaking, describing her worsening cardiac symptoms and mentioning that she had already been discharged from one hospital that day. "Ma'am, I'm dispatching an ambulance to your location right away," the dispatcher said. "Try to stay calm and keep the line open until the paramedics arrive. Is there anyone else in the apartment with you?" Sarah confirmed that she was alone and provided additional information about her location and how to access her building. As she waited for the ambulance, she tried to prepare herself for another round of medical skepticism, but she was determined to be more assertive about her needs and more specific about the progression of her symptoms since her earlier discharge. The sound of sirens approaching her building provided a small measure of relief, but Sarah knew that the real battle was just beginning. She had survived enemy fire, improvised explosive devices, and some of the most dangerous military operations of the past decade, but she had never faced a challenge that required her to fight for her life against a system that was supposed to be helping her. The paramedics who responded to Sarah's second emergency call were a different team than the morning crew, consisting of a woman named Angela Martinez and a younger male partner named David Chun. Martinez had 20 years of experience in emergency medical services and had developed a reputation for thorough patient assessment and advocacy, particularly for patients whose conditions might be overlooked by hospital staff. When they arrived at Sarah's apartment, Martinez immediately noticed the severity of her condition and the marked deterioration since the morning's incident report. Sarah's skin had taken on a grayish pallor, she was struggling to speak in complete sentences due to breathing difficulties, and her vital signs showed significant abnormalities that couldn't be attributed to anxiety or panic disorders. "Miss Mitchell, I'm Angela Martinez, and this is my partner David Chen. I understand you were treated at Harborview earlier today, but your condition appears to have worsened significantly since then. Can you tell me what's been happening since you were discharged?" Sarah appreciated Martinez's direct approach and professional demeanor. Unlike the morning paramedics who had seemed skeptical of her symptoms, Martinez appeared to be taking her condition seriously and focusing on gathering accurate medical information rather than making assumptions about her situation. The chest pain has become severe and constant, Sarah explained, pausing frequently to catch her breath. My heart rhythm feels completely irregular, and I'm having episodes where it feels like my heart stops beating for several seconds. The numbness has spread to both arms, and I'm experiencing what feels like electrical shocks through my chest. Martinez nodded as she listened, taking detailed notes and conducting a thorough physical examination. She checked Sarah's pulse at multiple points, noted the irregularities in her heart rhythm, and observed her breathing patterns with the attention of someone who understood that subtle changes could indicate serious underlying conditions. David, let's get a full set of vitals and run a 12-lead EKG right here before we move her, Martinez instructed her partner. I want to see what's happening with her cardiac rhythm before we transport. Chen quickly set up the portable EKG machine while Martinez continued her assessment, asking Sarah about her military background and whether she had been exposed to any unusual environmental factors during her service that might be relevant to her current condition. I was deployed 3 times to Afghanistan, primarily in mountainous regions, Sarah replied. I was exposed to burn pits, extreme altitude changes, and various environmental hazards, but my military medical records showed no cardiac issues at the time of my discharge. Martinez made detailed notes about Sarah's military service, recognizing that veterans sometimes develop delayed-onset medical conditions related to their deployments that weren't immediately apparent during routine military physicals. Her experience with veteran patients had taught her that military training often made them highly accurate reporters of their own symptoms and physical condition. When the EKG results printed out, Martinez's expression became serious as she reviewed the readings. The test showed significant abnormalities that were clearly outside normal parameters, including irregular rhythms and changes that suggested possible damage to the heart muscle. Miss Mitchell, this EKG shows definite abnormalities that need immediate evaluation by a cardiologist. We're going to transport you to University of Washington Medical Center, which has a specialized cardiac unit and staff who are experienced with unusual presentations of heart disease. Sarah felt a wave of relief at finally having her symptoms validated by a medical professional, but she was also concerned about returning to a hospital environment where she might face the same dismissive attitude she had encountered earlier in the day. Will you be able to communicate to the hospital staff about what you've observed? Sarah asked. I'm worried that they'll see my age and assume this is anxiety-related, like what happened this morning. Martinez looked directly at Sarah with an expression of professional determination. Miss Mitchell, I'm going to personally hand over your care to the cardiac team at UW Medical Center, and I'm going to make sure they understand that you're experiencing a genuine cardiac emergency. Your symptoms and test results speak for themselves, and I won't leave until I'm confident you're receiving appropriate care. During the ambulance ride to University of Washington Medical Center, Martinez continued monitoring Sarah's condition and documented the progression of her symptoms throughout the day. She also contacted the receiving hospital to provide advance notice about the case and specifically requested that Sarah be evaluated by the cardiac emergency team rather than general emergency medicine staff. Sarah's condition continued to deteriorate during transport, with increasingly frequent episodes of irregular heartbeat and chest pain that was becoming difficult to manage even with the pain medication that Martinez had administered. At one point, Sarah's heart rate dropped to dangerously low levels before suddenly spiking to over 150 beats per minute, a pattern that concerned both paramedics. David, radio ahead and tell them we need the cardiac team standing by when we arrive, Martinez instructed. This patient is showing signs of significant cardiac instability, and she's going to need immediate intervention. University of Washington Medical Center had a different atmosphere than Harborview, with specialized units and staff who were accustomed to treating complex cardiac cases. When Sarah's ambulance arrived, she was met by Dr. Jennifer Patel, a cardiologist who had extensive experience with unusual presentations of heart disease in young patients. Dr. Patel reviewed the EKG results and Martinez's detailed report while simultaneously conducting her own examination of Sarah. Unlike Dr. Webb's dismissive approach earlier in the day, Dr. Patel asked specific questions about Sarah's symptoms and listened carefully to her answers without making assumptions about their psychological origin. Miss Mitchell, the EKG changes that the paramedics documented are definitely concerning and need immediate investigation. I'm going to order a series of tests including cardiac enzymes, an echocardiogram, and, potentially a cardiac catheterization to determine exactly what's happening with your heart. Sarah felt overwhelmed with gratitude at finally being taken seriously by a medical professional. Dr. Patel, I want you to know that I was discharged from another hospital this morning where they told me my symptoms were anxiety-related. I've been getting progressively worse throughout the day, and I was starting to think I might not survive this. Dr. Patel's expression became serious as she processed this information. Miss Mitchell, based on what I'm seeing right now, you're experiencing a significant cardiac event that requires immediate treatment. The fact that you were discharged earlier with these symptoms represents a serious failure in medical assessment, and I'm going to make sure we get to the bottom of what's happening. The cardiac team at UW Medical Center moved with impressive efficiency, conducting a series of tests that provided a complete picture of Sarah's cardiovascular condition. The results revealed a condition that Dr. Patel had suspected based on Sarah's age, gender, and symptom presentation, but which required advanced diagnostic techniques to confirm definitively. Miss Mitchell, the tests show that you're experiencing something called spontaneous coronary artery dissection, or SCAD, Dr. Patel explained. It's a condition where the wall of one of your coronary arteries develops a tear, which disrupts blood flow to your heart muscle. It primarily affects young, healthy women, and it's often misdiagnosed because it doesn't fit the typical profile of heart disease. Sarah listened intently as Dr. Patel explained the condition, feeling validation that her symptoms had been real and serious despite the dismissive treatment she had received earlier. Is this condition life-threatening? And why wasn't it detected at the other hospital? Dr. Patel chose her words carefully, balancing honesty about the serious nature of Sarah's condition with reassurance about the treatment options available. SCAD can be life-threatening if not properly treated, especially if the dissection extends or if it triggers dangerous heart rhythms. The condition is often missed in emergency room settings because it's relatively rare and because the symptoms can be attributed to other causes in young women. The treatment plan that Dr. Patel outlined was comprehensive and required immediate intervention to prevent further damage to Sarah's heart muscle. The cardiac team would need to perform a procedure called cardiac catheterization to visualize the coronary arteries and determine the extent of the dissection, followed by possible stenting or other interventions to restore normal blood flow. Miss Mitchell, I need you to understand that we're dealing with a serious medical emergency here, but it's one that we can treat effectively if we act quickly. You are absolutely right to advocate for yourself and seek additional medical attention when your symptoms worsened. As Sarah was prepared for the cardiac catheterization procedure, she reflected on the remarkable turn of events that had brought her from near-death dismissal to appropriate treatment within a matter of hours. The difference in medical care between the two hospitals had been dramatic, highlighting the importance of finding healthcare providers who were willing to look beyond demographic assumptions when evaluating patient symptoms. Angela Martinez, the paramedic who had advocated for Sarah's care, stopped by the cardiac unit before ending her shift to check on Sarah's progress. She had made a point of following up on cases where she felt patients had received inadequate initial care, and Sarah's situation had particularly concerned her given the severity of her condition and her history of military service. Miss Mitchell, I'm glad to see you're getting the care you need, Martinez said. I wanted to make sure you understood that what happened to you this morning was not acceptable medical practice. Your symptoms were real, your condition was serious, and you deserved proper evaluation from the beginning. Sarah thanked Martinez for her advocacy and professional expertise, recognizing that the paramedics' intervention had quite literally saved her life. Angela, if you hadn't taken my symptoms seriously and brought me to a hospital with cardiac specialists, I don't think I would have survived the night. You believed me when other medical professionals wouldn't. As the medical team prepared Sarah for her procedure, Dr. Patel provided additional information about spontaneous coronary artery dissection and why it was frequently misdiagnosed in young women. The condition affected approximately 1 in 10,000 people annually, but the majority of cases occurred in women under 50 who had no traditional risk factors for heart disease. The medical literature shows that women with SCAD often experience significant delays in diagnosis because their symptoms are attributed to anxiety, panic disorders, or psychosomatic conditions, Dr. Patel explained. This bias in medical care can have serious consequences, as you've experienced firsthand. Sarah found it both validating and disturbing to learn that her experience was part of a broader pattern of medical discrimination against young women presenting with cardiac symptoms. The knowledge that other women had suffered similar dismissive treatment provided context for her experience, but it also highlighted the systemic nature of the problem within the healthcare system. The cardiac catheterization procedure revealed the full extent of Sarah's condition and confirmed Dr. Patel's diagnosis of spontaneous coronary artery dissection. The imaging showed a significant tear in one of her major coronary arteries that had been progressively restricting blood flow to her heart muscle throughout the day. "Miss Mitchell, the good news is that we've identified the problem and we can treat it effectively," Dr. Patel announced after reviewing the catheterization results. "We're going to place a stent in the affected artery to restore normal blood flow and prevent further damage to your heart muscle." The successful completion of Sarah's cardiac intervention marked a turning point in her medical crisis, but it also raised important questions about the quality of emergency medical care and the biases that could prevent patients from receiving appropriate treatment. As she recovered in the cardiac unit, Sarah began to understand that her survival had depended not just on her own persistence in seeking care, but on encountering medical professionals who were willing to look beyond superficial demographic factors when evaluating her condition. The recovery process following Sarah's cardiac procedure gave her time to reflect on the extraordinary events of the past 24 hours and to process the reality that she had nearly died from a condition that should have been treatable if properly diagnosed. As she lay in the cardiac intensive care unit, connected to monitors that displayed her improving heart rhythm, Sarah began to understand the broader implications of her experience beyond her personal medical crisis. Dr. Patel visited Sarah regularly during her recovery, not only to monitor her cardiac status but also to discuss the systemic issues that had contributed to her delayed diagnosis. As a cardiologist who specialized in treating young women with unusual presentations of heart disease, Dr. Patel had seen too many cases where patients' symptoms were dismissed or misattributed to psychological causes. "Miss Mitchell, I want you to know that what happened to you represents a significant failure in our medical system," Dr. Patel said during one of her visits. Spontaneous coronary artery dissection is a well-documented condition with clear diagnostic criteria, but it continues to be missed because many healthcare providers don't consider cardiac causes when evaluating young women's chest pain. Sarah appreciated Dr. Patel's honesty about the medical system's shortcomings, but she was also curious about the broader scope of the problem. "Dr. Patel, how many other women have experienced similar situations? And what can be done to prevent this kind of diagnostic bias in the future?" Dr. Patel explained that research studies had documented significant gender disparities in cardiac care, with women more likely than men to have their symptoms attributed to anxiety, stress, or psychosomatic causes. Young women were particularly vulnerable to this bias because they didn't fit traditional profiles for heart disease, despite the fact that conditions like SCAD primarily affected their demographic group. The medical literature shows that women with cardiac symptoms wait longer for treatment, receive less aggressive interventions, and have worse outcomes partly due to these diagnostic delays, Dr. Patel continued. "Your military background actually worked against you in some ways, because healthcare providers may have assumed that someone with your training and fitness level couldn't possibly be having a heart attack." As Sarah's physical condition improved, she began to consider how her unique perspective as both a patient and a Navy SEAL veteran might be valuable in addressing these systemic issues. Her military experience had taught her the importance of after-action analysis and process improvement, skills that could potentially be applied to healthcare quality improvement initiatives. Angela Martinez, the paramedic who had advocated for Sarah's appropriate care, had become an unexpected ally in helping Sarah understand the EMS system's role in addressing diagnostic bias. Martinez visited Sarah during her recovery and shared her own observations about how patient advocacy could make a life-or-death difference in emergency situations. "Sarah, in my 20 years as a paramedic, I've learned that sometimes we have to be advocates for our patients when the healthcare system fails them," Martinez explained. "Your case is going to be part of my continuing education presentations because it perfectly illustrates how dangerous it can be when medical professionals make assumptions based on demographics rather than symptoms." Sarah was moved by Martinez's commitment to using her experience to educate other emergency responders about the importance of thorough patient assessment regardless of age, gender, or apparent health status. The idea that her near-death experience might prevent similar situations for other patients provided a sense of purpose that helped her process the trauma of her medical crisis. Dr. Jennifer Patel had been conducting research on gender disparities in cardiac care for several years, and she asked Sarah if she would be willing to participate in a study documenting patient experiences with diagnostic delays. The research was designed to identify specific factors that contributed to misdiagnoses and to develop training programs for healthcare providers. Ms. Mitchell, your case is particularly valuable for our research because you can articulate the progression of your symptoms and the medical responses you encountered with the precision of someone trained in objective observation, Dr. Patel explained. Your military background gives you a unique ability to analyze the decision-making processes that led to your initial misdiagnosis. Sarah agreed to participate in the research, recognizing that her experience could contribute to broader improvements in cardiac care for women. The interview process required her to provide detailed accounts of every interaction with healthcare providers, from the initial paramedic response through her successful treatment at UW Medical Center. During these interviews, Sarah gained insights into the subtle biases and assumptions that had shaped her medical care. The researcher conducting the interviews pointed out patterns in the language used by different healthcare providers and the ways that Sarah's age, gender, and appearance had influenced their clinical decision-making processes. It's striking how the same set of symptoms were interpreted completely differently by different medical teams, the researcher noted. The EKG abnormalities that Dr. Webb dismissed as minor variations were immediately recognized as significant cardiac pathology by Dr. Patel and her team. As word of Sarah's case spread through the medical community, she began receiving requests to share her story at medical education conferences and training seminars. Healthcare institutions were increasingly recognizing the need to address diagnostic bias and improve care for patients who didn't fit traditional disease profiles. Sarah's first speaking engagement was at a regional emergency medicine conference, where she presented alongside Dr. Patel and Angela Martinez to provide multiple perspectives on the same medical case. The audience of emergency physicians, nurses, and paramedics listened intently as Sarah described her experience from the patient's perspective. I want you to understand that I'm not here to criticize individual healthcare providers, Sarah told the audience. I'm here because I believe that systemic changes in how we approach patient care can save lives. The same symptoms that were dismissed as anxiety at one hospital were correctly diagnosed as a life-threatening cardiac condition at another. The difference wasn't in my condition but in how that condition was evaluated. The response to Sarah's presentation was overwhelmingly positive, with many healthcare providers expressing appreciation for her willingness to share such a personal and traumatic experience for educational purposes. Several physicians approached her after the presentation to share their own observations about diagnostic bias and their commitment to improving their clinical practice. Sarah's story also caught the attention of patient advocacy organizations and women's health groups who were working to address gender disparities in medical care. She was invited to participate in policy discussions about healthcare quality improvement and to provide input on training programs designed to reduce diagnostic bias. Through these activities, Sarah discovered a new sense of purpose that helped her process the trauma of her medical crisis while contributing to meaningful change in the healthcare system. Her military background in leadership and problem-solving proved valuable in these advocacy roles, allowing her to communicate effectively with medical professionals and policymakers. The job interview that Sarah had been preparing for on the morning of her cardiac event seemed like a distant memory compared to the opportunities that were emerging from her patient advocacy work. Several organizations offered her positions that would allow her to combine her military experience with her newfound expertise in healthcare quality improvement. Sarah ultimately accepted a position with a national patient safety organization that worked to reduce medical errors and improve healthcare outcomes for vulnerable populations. Her role involved developing training programs for healthcare providers, conducting research on diagnostic bias, and advocating for policy changes to address systemic inequities in medical care. 6 months after her cardiac event, Sarah participated in a follow-up conference where Dr. Patel presented research data showing improvements in cardiac care for young women at hospitals that had implemented bias training based partly on Sarah's case. The data indicated that healthcare providers who had received this training were more likely to order appropriate cardiac testing for young women presenting with chest pain symptoms. Miss Mitchell's case has become a powerful teaching tool that helps healthcare providers understand the real-world consequences of diagnostic bias, Dr. Patel announced to the audience. Her willingness to share her experience has contributed to measurable improvements in patient care. Angela Martinez had also been promoted to a supervisory role in her EMS system, where she was responsible for training new paramedics about patient advocacy and thorough assessment techniques. She frequently used Sarah's case in her training programs to illustrate the importance of questioning assumptions and advocating for patients who might not receive appropriate care. The legal aspects of Sarah's case were resolved when Harborview Medical Center agreed to implement comprehensive training programs about gender bias in emergency medicine and to establish protocols for second opinions in cases where young patients presented with potentially cardiac symptoms. While Sarah chose not to pursue financial compensation, the institutional changes represented a meaningful acknowledgement of the systemic problems that had nearly cost her life. Dr. Marcus Webb, the emergency physician who had initially dismissed Sarah's symptoms, participated voluntarily in the quality improvement initiatives that emerged from her case. He publicly acknowledged that his approach to Sarah's care had been influenced by unconscious biases and committed to changing his clinical practice to prevent similar diagnostic errors. Miss Mitchell's case taught me that I had been making assumptions about patients based on demographics rather than focusing solely on their clinical presentation, Dr. Webb stated during a medical education conference. Her experience has fundamentally changed how I approach patient care, particularly for young women presenting with symptoms that could indicate serious cardiac conditions. Sarah's recovery from her cardiac event was complete, with follow-up testing showing normal heart function and no residual effects from the spontaneous coronary artery dissection. However, the psychological impact of nearly dying from a preventable medical error continued to influence her perspective on healthcare and patient advocacy. 1 year after her cardiac crisis, Sarah was invited to speak at the graduation ceremony for a new class of Navy SEALs, where she shared how the leadership and analytical skills developed during military service could be applied to civilian challenges, including healthcare advocacy. Her speech emphasized the importance of persistence, objective assessment, and fighting for what was right even when facing seemingly insurmountable obstacles. The same determination that gets you through SEAL training can save your life in a hospital, Sarah told the graduates. Never accept dismissive treatment when you know something is seriously wrong. Trust your training, trust your instincts, and never give up fighting for appropriate care. Sarah's story had transformed from a near-tragic medical error into a catalyst for meaningful change in healthcare delivery. Her experience demonstrated that individual patient advocacy, combined with systematic efforts to address institutional bias, could create improvements that benefited countless other patients facing similar challenges. The legacy of Sarah's ordeal continued to influence medical education and patient care protocols years after her initial cardiac event. Her case became a standard teaching example in medical schools, nursing programs, and emergency medicine training curricula across the country. Sarah Mitchell had survived enemy fire in Afghanistan and overcome the challenges of transitioning from military to civilian life, but her greatest battle had been fought in a hospital bed against a medical system that had nearly failed her completely. Her victory in that battle had created ripple effects that continued to save lives and improve care for patients who might otherwise have been dismissed or overlooked. Through her advocacy work, speaking engagements, and research participation, Sarah had found a way to transform her traumatic experience into a powerful force for positive change. The young woman who had once been told to let her die had become a voice for all patients who deserved better care, proving that sometimes the most important battles are fought not with weapons, but with words, determination, and an unwavering commitment to justice.